Dear Chairman, I thank the organizing committee for inviting me, and I thank Professor Lange for educating me, sir. My talk should be about intervention and hybrid therapy, but much was said about it already, and I don't want to go into the technique. Transcatheter VSD closure was first described for muscular VSDs by Jim Locke in 1808, and he did all the basic work on that. He described the arterious venous loop we have to do still today in most cases. And he also described that the position of the defect, which should be closed, determines the venous access point. So if the defect is apical, we have to go from the jugular vein, and if the defect is more up, as also in the perimembranous defect, we have to go from the venous, from the femoral vein. And he proved the concept. But at that time, he did it with the Reshkind umbrella and other not suited occlusion devices, despite that it was feasible, and since then we've gone a long way. So transcatheter VSD closure today, we can close multiple types of defects. All congenital defects are tackled, post-surgical defects, post-myocardial infarction, and also traumatic defects have been closed. We can do it in nearly all locations you already saw: perimembranous, with or without septal aneurysm, perimembranous, with or without aortic prolapse, some do that really, or aortic regurgitation also, muscular VSDs, subarterial VSDs. Multiple devices are used. Most of them are the Amplatz type. It's not the Amplatz company anymore, but more or less it's a family of devices with symmetric double discs, with asymmetrical double discs, with single disc, which is used in the PDA also, and there's also one coil developed by Dr. Ley from Bremen, which is suited for interventional closure. And we have evolving techniques. We have the traditional technique by Locke. We have direct transarterial retrograde access, which was already described in 2006, but not many people did it because the sheath was very large and very stiff. But now with the small ADO2 devices and something like that, many people do the direct transarterial retrograde access already in infants, because you need only a 4 French or 5 French catheter and not anymore a 6 French or 8 French sheath. So that's much smaller. There is also a transvenous transseptal approach, and the newest development, we saw it in Frankfurt a few weeks ago, is direct transvenous undergrad access with echo guidance when the interventionist puts through the vein the catheter directly through the defect and then closes the defect without even doing an arterial puncture. So all this can be done. The question is, should it be done? And what's the point if we also have surgery? And we have seen that surgery is also a very good option. So there is only one prospective randomized trial which compares perimembranous VSD transcatheter closure to surgery. That's all we have. And this is 200 children, aged 3 to 12 years. That was a prerequisite. And if you see, it's difficult to read, but 100 children in each group, only 1/3 had clinical symptoms, only a little bit more than 1/2 had signs of volume overload. All the others were asymptomatic, and some of the patients were already only enrolled because, it's written in the paper, the parents insisted on closure. So much to indications for surgery and for interventional closure. We have 2 years follow-up in this study, and the mean defect size was a little bit larger in the surgical group, but this was randomized, that's not significant, and the shunt was nearly the same between the groups, and they used symmetrical Amplatz type occluder only, and then they compared, and the only problems noted were things inherent to surgery. So more blood in surgical patients and a little bit longer hospital stay and ICU stay. So the patients with intervention didn't even go to the ICU. So that's all the difference they tell us. And no patients had problems at follow-up. So that's the only study we have in direct comparison. However, there are other studies comparing, but those patients are not randomized, and the criteria, how they were treated, are different. We already saw this. Stefan showed us. It's a meta-analysis of 7 trials with 3,000 patients, 1,300 transcatheter, 1,800 surgery, different ages. This was significant. The transcatheter patients were 12 years old, the surgical patients were 5 years old. The defect size was more or less comparable, transcatheter 5 millimeters, surgical 6 millimeter mean. But, and the follow-up was very different, 5 to 24 months, and there was no difference in procedural success rate. The relative risk rate was 1.0. The major complication rate from death, reoperation, or permanent pacemaker as a composite endpoint was also only slightly different. The relative risk rate was a little bit towards percutaneous closure and negative to surgery, but this was not significant. So more or less it's the same from this major complication rate. And even the rate of advanced heart block was more or less the same, relative risk rate about 1. So no big difference. So why not close the defects interventionally? Yeah, because we don't know what's behind this meta-analysis. There is a new meta-analysis. I have to go back, sorry. Yes, from last year with 54 publications, more than 6,000 patients, only peroneus membranous VSD closure. Mean age in the study groups between adult groups with 37 years mean and infant groups with mean age 1.6 years, and the median follow-up was very different, and they report a success rate of nearly 100%, so only few problems. And the complications which are interesting for us are especially residual shunt, but the residual shunt was permanent only in less than 2%. So that's a problem which may occur early, but goes away mostly. And only 4 patients of this more than 6,000 patients had required a redo, either surgical or interventional. The arrhythmia rate, which seems to be very high, 10%, is only in 2% of the patients, but 2% is a lot, permanent, and a complete AV block is only 1%, and pacemaker, permanent pacemaker was necessary only in 33 patients of more than 6,000, so that's less than 1%. Some had to have transient pacemaker, some had to have other problems, and some had to have the procedure aborted due to interventional complete block. Valvular damage is also a point of concern, 4.1%, and most of them in tricuspid position. Some of them are aortic regurgitation, but device removal and valvular surgery was only in very few patients performed according to these data. But is everything published? I have to talk about perventricular hybrid VSD closure. That's interesting, and Professor Heinemann would be interested because the animal study done by Said Amin with long-term follow-up of the animals was published after the first report in men, published by Emil Bacher and Ziad Hijazi 1 month before, same journal. First, the study in men without animal before, then the researcher who did a lot. We've seen it already by Dr. Siepe, how this is performed, how this is done. Yeah, there is a multi-center study of the German working group. Ina Michel-Behnke has published it, and it showed that you can do this perventricular hybrid VSD closure in all types of defect also. You can put it in muscular defects, perimembranous, doubly committed, and post-infarction VSD, or you can do it as a sutureless patch in more complex surgery, where you put in the device instead of a patch, and additional procedures can be performed at the same time. So the question is not how to do it, the question is it is helpful. And there is no comparative study between this hybrid approach and surgery, and also not between this hybrid approach and transcatheter approach. There is, however, a meta-analysis with 17 publications, case 6 to more than 400 patients per study, and with use of symmetrical and asymmetrical Amplatz-type devices. The reported procedural success rate is between 82%, which is probably very honest, and 100%, which maybe is less so. And the possibility of intraoperative conversion was treated different in the studies. Some of the patients, some of the studies didn't mention that there was this conversion, and only rated the outcome, which was the result of this, and then started the follow-up. So few complications are reported, few residual shunt, and uneventful follow-up in at least most cases. So let's go a little bit more into that. There is one retrospect analysis comparing perventricular closure to surgery with 90 patients who were enrolled, and 7 were switched during the procedure. So in the end, 49 patients remained in the perventricular group, and 41 patients were in the surgical group. But in the beginning, 56 patients had entered the perventricular group, but then they changed. So you see the age is more or less the same, the weight is more or less the same, and now we come to the problems. This is before. So we see the residual shunt was, in contrast to what Stefan said, more in the perventricular group, 7 out of 49, and in the surgical group it was 1 out of 31, but it was considered not significant. I cannot control this. And on the other hand, the surgical related problems were more, of course, in the surgical group, especially the hospital stay. All the other things were not significant. So there's already a next step now, and we didn't discuss whether that's the way to go, that it's percutaneous perventricular device closure, not with sternotomy, not with complete or not minimal invasive sternotomy, no, only puncture. The report is on 16 patients, 15 were successful, needle puncture of the RVOT through the chest wall, device closure first of the VSD, then device closure of the right ventricular anterior wall, then glue to the pericardium, and then wait and see. And only 1 patient had a drainage of a pericardial effusion, all the others, it did well, so maybe that's the next step. I don't know. Let me conclude. Transcatheter and periventricular occlusion are valuable alternatives to classical VSD surgery. However, they are not superior to classical surgery. We have to keep that in mind. Early or late AV block is a low risk. In the meantime, we had a phase where we thought in little children that might be 5% risk or more. The studies today don't show this. It's a low risk, but a significant risk, and it can also occur late. Pre-existing prolapse of aortic valve and peri-interventional tricuspid valve damage are relevant problems. However, some groups tackle also patients with aortic valve prolapse and with aortic valve insufficiency and seem to have good results, but we have to wait for late follow-up. Therefore, I think careful patient selection is of utmost importance, despite you don't find it in the literature. So this is something every team has to decide itself, and I can give no recommendations because it's not part of the literature. Thank you very much.